So today we have the pleasure of welcoming Stéphane Bédouani, who is a clinical physicist at the Centre Hospitalier de l'Université de Montréal and affiliated professor at the Université de Montréal as well in their medical physics program. He's here for most of the day. He was meeting with my group this morning, and I believe he's meeting with Jan's group later today and with some members of John's group as well through the afternoon. So he's gracious with this time and spending some good amount of time with us. He holds a PhD from Polytechnique, Montreal, and like me has come to radiation therapy a bit from the outside of the spectrum, if you want. Maybe further outside, in fact, because you've done work well outside of medical physics, peripheral. And I believe he was a resident at the Université de Montréal before serving as a PhD as a physicist. No nope. Residency program. Okay. I stand corrected. And today he's going to talk to us about his work in functional imaging of lung perfusion using dual energy CT applications to radiation therapy. Thank you.
Well, thank you very much, Yves, for this for the invitation. And so, first of all, sorry for my poor English, but I hope that you will at least enjoy the content of this presentation. So, as you said, this talk is about it's about functional imaging of lungs perfusion using dual energy computed tomography in radiation therapy. So, in 2013, we were probably the first in North America in the Department of Radiation Oncology to obtain a dual energy CT from Siemens. It's the definition flash. And in 2017, we moved from Notre Dame Hospital to the CHUM in downtown Montreal. And so, of course, by moving to this new hospital, that looks okay. It's not perhaps as colorful that MUHC. But we decided to also move the dual energy CT in this new hospital. So probably some of my colleagues already came here and talk about dual energy CT. So I will try to take another focus, and I will talk about the topic of contrast-enhanced dual energy CT. So the reason why we want to look at this problem is to assess the lung function for potential application in radiation oncology. But usually when you talk about lung function, you use other type of imaging. So you may use exam from nuclear medicine. And here we'll propose an alternative using contrast-enhanced dual energy CT. So I will start with a little introduction on both nuclear medicine and DCT, and then move to the core of this talk about quantitative contrast-enhanced dual energy CT. And then we'll see that this can give us information on the iodine concentration, and this information can be assessed for lung function. And then we'll see how we can monitor lung function after a treatment of radiotherapy. And I will finish with a small conclusion. So many of the patients that we see in radiation oncology with a lung cancer already suffer from some pulmonary disease, for example, emphysema, fibrosis, or COPD. And often, when one of these disease is present, there is also a local loss in the lung function. So in this image, we see a dark spot, but I put a blue arrow on it. This is some form of emphysema. And often this is also, it will mean that this part of the lung will probably lack of function. So this is just to give you a little reminder, the goal in lung cancer radiation therapy is to administer a prescribed dose to a tumor while minimizing the dose to the surrounding healthy lung tissues and also to other organ at risks. So there is several ways to address lung function. There is many medical exams that can be performed, but I like to see the lung function by going back to the primary function of the lungs, which consists to exchange oxygen and carbon dioxide. So one way to do it is to use a single photon emission computed tomography, or SPECT. There is two exams that are more common. There is the V exam, which consists to inhale a radioactive gas, and then we can see with the amount of counts, we can see the strength of the airflow. And there is another exam, the Q exam, the perfusion exam, that consists to inject a radioactive agent in a vein, and we can then assess the blood flow also by using the counts. So in the picture here, you have several images of a patient that received both a ventilation and a perfusion exam. What would be an interest is if we want to know how good is the functional level for breathing, you will need to combine both information together. Where there is a lot of ventilation, it's the dark spots, and where there is a lot of perfusion, it's where there is also dark spots. So you have to combine both of them to have a good breathing level. But if we look carefully to these images, perhaps we kind of notice that the ventilation appears quite homogeneous on the image, and the perfusion is more localized. So we can perhaps have put a more emphasis on the perfusion. So for the rest of this talk, we'll try to assess the lung perfusion instead of the lung ventilation. And with another technique than SPECT-CT, we'll rather use dual energy CT. But to come back to our patient with the emphysema, here we have an example of a SPECT-CT image where the red map is overlaps the CT image, and the red map is the SPECT-CT image, so the amount of counts. What is interesting is that indeed the lobe, the pulmonary lobe that contains emphysema, doesn't show a lot of counts. So there is a loss of functionality in this part. But can we use this in radiation therapy? Probably, but we need to face a few limitations of the SPECT-CT. First, it requires an additional exam that may last for 45 minutes. And also the spatial resolution of SPECT is usually much less than CT. So if you plan to combine this information during planning, might not be the best choice. And also, I said that the acquisition takes several minutes, so it means you breathe several times, you have different amount of breathing cycle. So there will be a blurry image because because of the motion of the lungs. So to address some of these limitations, we might try to investigate another modality, and we'll look at the dual energy CT. So there is many technology that exists, but I will focus on the dual source CT from Siemens, which this is the one we use in our department. So mainly you have two X-ray sources that are phased. They have a different angle of 90 degrees almost, and each source has its own detector. And also each source may have different tube voltage. So when we think of the benefits of using a dual energy CT, it's kind of adding a new information to the conventional CT images. So to image this concept, I like to show this quite easy question. What's the flag of which country is associated to this flag? Well, even though you don't have the colors, this is a grayscale image and can be associated to the single energy CT. It's quite enough to identify the country. But if you're using a single energy CT in radiation therapy, it's usually enough because you can do contour, you can do planning, you can do patient positioning. So there's no need for extra information. But in some cases, it might be useful to have more information. And that's why I'm asking you, what's the country of the second flag? Could be France, could be Italy, Ireland, Belgium. I don't know. Well, I do know because I made the image.
Which one is it?
So it's Italy. So adding extra information would be kind of adding colors to this image, and we can answer the question. So there is many other benefits of dual energy CT in radiation therapy. It can be used to have a better tissue characterization for advanced dose calculation in brachytherapy. It may also improve accuracy on estimating proton stopping power in proton therapy. But today, where we will focus is on how it can be used for quantification of iodine concentration from a contrast-enhanced acquisition. So there is a lot of stuff you can do with a dual energy CT, and that's why I listed a few of our papers we did in the last few years. So let's come back to the basic of dual energy CT, and more precisely about contrast-enhanced dual energy CT. It means that we added some iodine content inside the patient or inside our phantom. So here we have the Gamex 472 phantom, and I put 7 rods in the outer ring that have different value of calcium concentration. And inside, in the inner ring, you have 7 rods that contains different concentration of iodine. And when I make a CT image, you will notice that two rods may have the same HU values, even though they don't have the same compounds. So the first thing to know is when we look at CT numbers, there are several things that may impact on these values. First, the effective atomic number, the electron density, and also the tube voltage. So using a dual energy CT, we can acquire another image at another energy. And this contrast will change and we'll be able to identify which of these roads is iodine or calcium. So this map that I have drawn here shows the HU value for the y-axis of a tube at 100 kV, and the x-axis shows the HU values for the tube at 140 kV. So if I take the mean HU for each rods in my phantom and I put it in this map, you will notice that there is two trends that are seen. The blue trend is all the plugs related to calcium, or if you want, to bones. And the red trend is all about iodine concentrations. So with this scheme, we can draw some boundaries, and the blue area would be all HUs pair that fall in the blue area would be considered bone, and otherwise it will be soft tissues. So this is a technique called material labeling. And when you have done this map, you can take a contrast-enhanced dual energy CT image of a patient and put all the HU in this map and assign a value to each voxel. So to give you some example of what it can do, I will show you some digitally reconstructed radiograph that I've made by using all the voxel of the CT volume, only voxel related to bones, only voxel related to soft tissues, and the last one is only voxels that contain iodine. So this gives you an idea of what you can do with material labeling. Well, this is quite simple to do. To have more application in radiation oncology, you need to have more information. We need to be more quantitative. So for the next step, I would like to change my page. We'll scroll. So for the next part of my talk, I would like to show that we can be more quantitative using contrast-enhanced dual energy CT. And first I need to give credit to my PhD student, Andréane Lapointe. She made her defense a few months ago, and the next slides are all our PhD work. So all her credit. So this work is divided in three phases, and the first phase was supervised by my colleague Hugo Bouchard, and the aim of this project was to quantify iodine concentration from these CT images. And this can be done by applying a two-material decomposition technique. However, to perform such method, you need a proper stoichiometric calibration that is adapted to the presence of iodine in the images. So basically, we took a method that we already developed with Arthur Lalonde and Hugo Bouchard, and we added more plugs that contains iodine. We did changes using weighted fits to put more emphasis on the iodine. But I won't go much on that topic today, and we'll move to the two-material decomposition and assume that the calibration is proper for the presence of iodine. So let's first define the reduced Hounsfield unit. I found it an elegant way to express the Hounsfield unit. So it's basically the linear attenuation of the medium divided by the linear attenuation coefficient of water. And this can be obviously be translated like the electron density over the electron density of water, which is the relative electron density. And then you have the second term, that is the electronic cross-section of the medium over the electronic cross-section of water, which we call F, the electronic cross-section relative to water. So when you are developing the reduced HU with the presence of a contrast agent, you may perform a linear combination of two materials that is expressed here. So basically, the first material can be any tissues, but in our case, we'll focus on lung, so it will be lung tissue. And the second material will be the contrast agent. So basically, the reduced HU will be the relative electron density times the relative electron cross-section times its electron fraction plus the electron fraction of the contrast agent times the relative electron cross-section of the contrast, which can be translated like this, where X1 and Xc are the partial electron density for each material. Since we are doing dual energy CT, we can express this as a linear system. So the reduced HU value at two different energy. Here, F1 and Fc are obtained using a stoichiometric calibration that I have talked briefly previously. And the unknowns are X1 and Xc, which can be solved in this case. By solving Xc, you also provide the information on the iodine concentration. So the iodine concentration is equal to the Xc over the relative electron density of the contrast agent, which can be determined knowing the molecule chemistry, and also by knowing the nominal iodine concentration of the OmniPac agent, in this case 350 milligram per milliliter. Now that we know the iodine concentration, we may address another problem. Can we use iodine concentration to assess the lung function? So the first step is to show this correlation and validate it with a nuclear medicine exam using SPECT-CT. So, as I said previously, the lung function can be related to the pulmonary blood flow. A SPECT-CT exam can assess the blood flow using the amount of counts, but we could also imagine a dynamic CT exam to assess the blood flow. However, this might be a bit difficult because you will have to study the blood flow for each voxel inside the lung, which might be a bit complicated. And then there is another way, using the contrast-enhanced dual energy CT that can be used to assess the perfused blood volume, which, fortunately for us, was determined to be a reliable surrogate to blood flow by Fuld et al. In 2013. We want to compare the functional level obtained with dual energy CT and with SPECT CT. However, these are two separate scans, and identifying which voxel correspond to which one in the lung is not feasible. So what we will do is to determine subvolumes in the lung that are similar for both techniques. So to assess the lung function, we will present you the differential function, which is essentially the sum of the functional level of each voxel inside a volume divided by the functional level of each voxel inside the whole lung. And if it's a SPECT image, then the functional level will be the number of counts per voxel, and for dual energy CT, it will be the iodine concentration per voxels. Now, one of our radiation oncologists was generous to draw all the subvolumes inside the lung for this study. And this was done in the CT image of the SPECT CT and also directly on the dual energy CT images. So you can see that now we have subvolumes that can be compared with each other. But to make a fair comparison between SPECT and dual energy CT, we need to look at the functional information that are equivalent. And one limitation of the dual energy CT is about the contrast injection, which is not necessarily stable through time. So if we look at a SPECT image, you introduce the injection and you can perform the image almost any time after the injection. And all the contrast agent will be kept inside the lung parenchyma. So to be more comparable to SPECT, we need to remove some areas inside the volumes that are related to place where the contrast agent in SPECT will not stay. Let's say the large vessels and also in the tumor. So these parts were removed from our volume and were considered as not contributing to the lung function in the dual energy CT images. So here are a few images that compares dual energy CT iodine map versus the counts map from SPECT CT. And for this patient, we can see that where the iodine content is high, the number of count also is high. And in this lobe, you can see that there is not much of presence of counts, and there is some emphysema that is present in this lobe. So both techniques can see that this lobe is not working well. You also see that one is more pixelized, more resolution resolved, and the other one is blurry. But now we can be a bit more statistical in our comparison. So I will compare the differential function that we obtained by DCT and SPECT CT for each lobe of 5 patients. So we have 25 data points in this plot. The black dots is the comparison between DCT and SPECT. And we see that there is a strong correlation showing a Pearson's coefficient of 91. So from this result, we can say that the dual energy CT can assess the lung function. now that we have this information, we can try to see if radiotherapy may have an impact on the lung function after treatment. So to evaluate the potential dose effect post-radiation therapy of lung cancer using contrast-enhanced dual energy CT. So to do so, we need to determine some way to monitor the functional response to the treatment. So we propose two metrics that answer to this question, and also we need to find a way to determine dose-related volumes for a longitudinal study, because we plan to obtain dual energy CT images pre-treatment, 6 months after treatment, and 12 months after. So we'll also have a little proof of concept using a small cohort. I will repeat again myself. Lung perfusion is hypothesized to be linearly correlated to the iodine content in the lung parenchyma. So, while this is true, if we look at the iodine concentration between two different scans at different time, we may not see this the same iodine concentration, even though there was no loss of function. This is one of the limitation of the contrast-enhanced technique. So to kind of correct this timing issue, we may try to find a way to normalize the images between two scan time. First way to do it is by using a metric that we call the relative function response, which is essentially the differential function for some volume at a time t that is 6 or 12 months at 6 or 12 months follow-up over the differential function of the same volume on pre-treatment. So if there is a loss of function, or this will be smaller. So this technique seems it's the easy technique to assume the differential function, because it's the common way to express lung function is using differential function. However, it assumes that the whole lung preserves its overall function from time to time. It means that if you lost, you have at time 0 you have good lungs, and at time 2 you have emphysema all over your lungs, they will consider that the lung function of the whole lung will be 100%. So it might not be the most suitable functional response for our study, but since it's often used, we'll present the result of this metric. The second metric that we call the normalized functional response is a bit different. So we will look at the iodine concentration at time t that can be 6 or 12 month follow-up inside a volume, and we will normalize it with the iodine concentration for another volume that is considered well perfused. So we assume that this small volume V star didn't lose function from time to time. And then we compare it with an equivalent term with pre-treatment data. next step is we have this matrix, but we need to compare equivalent volumes. So, and volumes that are related to the dose that has been received. So to do this, we'll take the pre-treatment CT images and of the lung, and we'll segment it with the dose distribution to obtain subvolumes with different range of absorbed dose. And then we'll take the CT image at 6 or 12 months, and we will deform them toward the pre-treatment image to get the volume related to a dose absorption. So this deformable registration of lungs was performed using the open source toolbox ANTS, which I will not develop much here, but here a reference to the paper on this tool, and which was developed to deform long images from different phase to another in 4D CT. So when you have performed this registration of the CT images, you obtain a deformation field, which can be then applied on the iodine map that we have generated from dual energy CT. But by doing so, the voxels inside our images will be stretched. So there will be a problem about conservation of the total mass of the iodine concentration contrast. So we apply some correction for the intensity of the iodine maps to preserve the mass of the iodine. So here an example of the CT images before treatment, and also the dose that was planned for this IMRT plan, and the iodine map for this lung structure. And at 6 and 12 months, we have registered the lung volume to the pre-treatment. So that's why they all have similar shape. And we can see that through time in the CT images, you have some sign of fibrosis appears at some places that are related to where the high doses over 20 gray was absorbed by the tissues. So if we look at the iodine concentration maps, there is some loss of iodine concentration exactly at the same place where the fibrosis appears. So this is a good assessment, visual assessment of the deformable registration, but we can be a bit more quantitative. Now, I propose two different metrics for the functional response to dose. And what we can see here is that each volumes, so here on the left is the 6 months follow-up image, and these are the result from a 12 months follow-up. We see that starting at 20 gray, we see a loss of the function using the relative functional response, and also the same things can be seen in the normalized functional response. So in conclusion, iodine concentration can be determined using material decomposition on contrast-enhanced dual energy CT. and iodine concentration provide functional information on the lung perfusion, as well as if we would have done it with a SPECT-CT exam. And finally, the lung functional response to radiation therapy treatment may also be addressed using dual energy CT. So we have a good framework to push this study a bit more further. So some future work we're working on is we have a 20-patient study that is ongoing at CHUM, and we'll evaluate the clinical impact of the radiation dose on the lung function using data at 6 and 1 year after treatment. And hopefully we'll get some significant clinical feedback. One other thing we are working on is that, okay, we have these beautiful functional maps. How can we introduce them in some plan system on some TPS to optimize the dose distribution? So to give you some idea of where we're going, we can see here that I computed the DVH for this plan, but also I considered functional volume, and we obtained different DVH that might be interesting to exploit during optimization, but it's still work in progress, and we need a lot of data to see what would be the new functional constraint. So I would like to thank everyone listed here, particularly Andréane for its great work at PhD, also Jean-François and Hugo, and also the radiation oncologist, Huda Baig. She's the one that drawn all the subvolumes of the lung. She did a great work with dual energy CT. And here a little picture of our group last summer. There are some people missing. And also I will do some advertisement. Our MSc and PhD program are now CAMPEP accredited, so you may spread the word. So thank you very much.
Thank you for a very interesting presentation of the real interface between physics research and clinical applications. Very interesting. Any questions? Questions from the Jewish maybe as well?
So, could you go back to that scatter plot you showed with the 0.9?
Sure.
So, the ones that seem like extreme outliers, do you have a sense of what's happening there?
Oh my, yeah. I don't remember exactly, but what can happen is sometimes we had some timing issue, and we scanned the patient too late or too early, and this may not provide good results. And also, as I said, this is a limitation, and one way to reduce the impact of such outliers is to be very, very rigorous on the acquisition times.
Because I would say even like looking at the points that are below the line, the fit is being pulled by the points above. The line really should be more like this way, and if you just got rid of them, it would fit much nicer.
Yeah, it will. In fact, the black line is not the fit. It's just a yeah.
So I have a question, in fact. So you talked about this issue of timing when it comes to the dual energy CT approach. Now, when you've suggested indices that would be timing independent, you seem to be talking about timing of the scan in the patient's process through follow-up. But I first understood the timing process as of catching the bolus. Is that the timing problem that you have? Is it catching the iodine bolus in the perfusion scan?
Yeah, this can be, that's what we do. We catch the bolus. That's not the problem. But if the heartbeat is different from a scan to another, if the anatomy changed for some reason, the iodine may not perfuse as well as would do as the same agent for the nuclear medicine exam.
Right, so presumably the nuclear medicine exam is a delayed contrast exam. So the contrast is just sitting there waiting to decay.
Exactly.
So you have a wide window of imaging. Whereas in CT, you have a bolus-driven technique.
Yeah.
And once the contrast agent is gone, it doesn't stay. Is it a sort of one pass or recirculated and that's it?
Exactly.
Okay.
It's one path. You don't know exactly if you took the image. It's a static image. It's not dynamic.
Yeah, of course. Yeah, and that brings about dose issues, right? If you're going to think, oh, let's image this dynamically, then there's dose issues. So in MR, the way people have thought about this is especially like in cardiac imaging. They've used either timing techniques, but now they have like bolus tracking approaches, which is kind of a quick scan or some kind of a scout scan that tells you, here's the timing of the contrast agent in this region, therefore start imaging at this time.
Yeah. And
I don't know if you've thought about that from a CT
we do
approach.
Exactly. This is what we do too.
It's already done.
Yes.
Okay.
But
Right.
it's not
It's not
enough.
good enough. And what about normalization, internal normalization inside the patient to, I don't know, the signal in the aorta or the vena cava, or
Yes.
is that something that you've
Yes.
looked at?
Yes. We thought of that. For other case, we look at the aorta and see how much iodine concentration was there, and try to normalize with that. Even the Siemens solution for extracting the iodinic concentration offers a normalization on a specific site. So
a manually defined point, you say, here's the iodine reference point, normalized to this, and that's still not solid enough. I see. Interesting. Logan.
Just for the dual energy CT system, the two energies that you're using where you have the plot, I assume those two energies are the ones that are just specific, like those are what's available on the system. Can you tune that at all, or is there like an ideal combination that you would use for your project?
So, if you look at this machine particularly, you have a very small set of energy that you can try. 80 kV, 100 kV, 140 kV, with and without a thin filter. So that's all. So you can make almost all these combinations together. Usually you want both spectra to be the most distinct from each other. But the 80 kV may have more noise, and the 100 kV would have been a better choice depending on the site you look at.